Hi everybody, my name is Kay Hoppy and I'm here today with a CCRN question for you. But before getting into the question, I want to tell you a little bit about me. My background is 40 years in nursing, with 37 of them being in the critical care areas. So I have worked in ICUs and CCUs and burn units and trauma units and neuro units, and I'm very passionate about raising the bar on critical care nursing practice. So that's why I'm here today. I am here and will be here every day to present a question of the day to you with rationale. So I encourage you to follow and share and like my questions, and you will be able to get them every day in preparation for the CCRN. And by the way, let me just say, on behalf of all of your patients and all of your families that you care for, I want to thank you for being interested in raising the bar on your critical care nursing practice. So without further ado, let's go ahead and do question of the day number 1. And again, if you follow, you'll be getting a question daily with rationale. So today we have a 66-year-old male that presents with retrosternal chest pain, diaphoresis, bradycardia, and hypotension. We do a 12-lead EKG, and the 12-lead EKG shows ST elevation in leads 2, 3, and AVF. The culprit coronary is most likely, and I purposely chose that culprit coronary thing because that's always on the exam, that word. What is the culprit coronary? So we have some choices here. We have left main coronary, we have left anterior descending coronary, the circumflex coronary, or the right coronary artery. I want to give you just a moment to look those over and come up with your answer, because then I'm going to give you the answer and we're going to talk about the rationale. Okay, everybody, so let's go ahead and come up with the answer. We have ST segment elevation in 2, 3, and AVF. 2, 3, and AVF are our inferior leads. They look at the inferior wall of the heart, which, by the way, is supplied by the right coronary artery. So the culprit coronary is most likely the right coronary artery. Now, here are some other things that kind of walk you down the path of that right coronary. First of all, this patient comes in with bradycardia and hypotension, which are very classic of an inferior wall MI. Very, very classic signs of an inferior wall MI, bradycardia and hypotension. So that kind of leads you down that path to begin with. So right coronary is the inferior, supplies the inferior surface of the left ventricle along with the right side of the heart. And oh, by the way, before we talk about the rationale as to why the other answers are not correct, I want to mention that about 1/3 of the patients that have an inferior wall infarct, they also have infarcted their right ventricle. And so it's really important when we have an inferior wall change, inferior wall MI, that we run a right-sided ECG and we set our sights on V4R, which is a chest lead over on the right side. We look for ST segment elevation in V4R because that is the most specific right-sided chest lead for right ventricular infarct. And we want to identify that because identifying an RV infarct identifies for us a very proximal RCA lesion, and it also kind of puts the writing on the wall for us as to what we can expect walking down the path and following this patient. We can expect with an RV infarction, we're going to have issues with RV failure, for example. So we look for signs and symptoms of right ventricular failure. So V4R is very specific, and we're looking for ST segment elevation there in V4R to determine that a patient has an RV infarct along with the inferior surface of the left ventricle. Now, the left main coronary, that's not the answer because The left main feeds flow into the LAD, the left anterior descending, and the circumflex. And so the EKG leads that are there in our scenario are 2, 3 AVF. The left main feeding flow into the LAD and the circ. Now, the left main is going to feed flow to the anterior and lateral surfaces of the left ventricle. And so anteriorly, we're going to pick up on it in leads V1 through V4, particularly if the septum's involved, because V1 and V2 are septal leads. V3 and V4 are true anterior leads. And then V5 and V6 are really looking more at the lower left lateral surface of the heart. So when we're talking about the left main, that's just plain old not the answer here. Neither is the left anterior descending. Just by its name alone, you can tell that it supplies the anterior surface of the left ventricle. The true anterior leads, like I just said, are V3 and V4, whereas if the septum's involved, we're going to see V1 and V2 changes as well. So LAD, not the answer. Last but not least, what about the circ, the circumflex coronary? Well, that comes around the left lateral wall of the heart, gives you a lateral wall MI, and the leads that we would pick it up in are leads 1, AVL, V5, and V6. So I hope this is a helpful question to get you on your way, and I will be back with you with another CCRN question tomorrow. Have a great day. Bye-bye.